Very good evening, everyone. We continue into the session 2 of our series, that is Ophthalmology Topics and MCQs. Uh, I would say that I hope you have revised the first session and you are that what we're discussing is actually 5-star ophthalmology topics in MCQs. And as I said further, and I said in the last session also, that this is the one which is applicable for both NEET PG as well as for your FMGE. So just give me a second. There is some technical issue. Just a minute. I would just restart in a while. There is some technical problem. Okay, so we are back. All right, I just connect. Technology has its own issues. You can use it to the best for yourself, but it has its own issues, right? Okay, so as I said, so this is something which is applicable for both NEET and FMGE, okay? So what we're discussing, as I said in the last one, is the 5-star ophthalmology topics and MCQs. Here I'm taking all the previous year questions and discussing the topics in details, right? Because every time when we are nearing the exam, what we are focusing is more of discussing the questions and remembering their answers. But now I want you that if there is a modified form of the question, so you can cover more questions from that topic, right? If everything is okay, there's no technical glitch, can I just have a thumbs up as a reassurance, and we'll start. So basically, reminding you back again with what I told you that day, we are celebrating a special learning week, which is a session of free classes, free special classes on the Unacademy app. And for ophthalmology, the date is 28th August, 9 p.m., where we meet to discuss about ophthalmology. And what are we discussing in that 1 hour? We'll be discussing about lasers, so commonly asked topics, so commonly questioned topics from the students, and retained intraocular foreign bodies, where I will cover siderosis bulbi and chalcosis, right? So, can I just have a confirmation, please, if everything is okay? So this is the session which is going to be on 28th August at 9 p.m. on the Unacademy app, and it's a free session, right? Following further, we have Target 150. What is Target 150? That is the ones who are targeting FMG December 2023 session, right? So 150 plus hours, live sessions, revision test and discussions, and last minute tips and tricks, right? So you can use my code for any additional advantages. Then Unacademy is offering you 20% off. Please note it is 20% off on all Unacademy subscriptions. So when I say on all subscriptions, but please note the date, it is till August 25th, right? So that is 20% off all on your subscriptions. And last but not the least, we have the iconic subscription where you get the Unacademy Plus, that is the live batches, recorded content. Then you have Question Bank 2.0 and test and quizzes, along with Notes 2.0 and a mentoring session included into it, right? So with all this backup, with all this backing, and I hope you have revised what we learned in the 5-star ophthalmology topics as MCQs session 1, which was on Monday. So with that, let's continue. So now we come to this point, and also one more thing. I have been writing the important topics again and again. So on 28th, I will give you a list of FMG important topics and most frequently asked topics, right? So that is also one thing which I would like to add here, that we will get on in this session, that is the FMGE. We will have FMGE, or I would say even for NEET, I will give you ophthalmology most commonly asked topics. So that are the topics that are not to be left unread, unlearned at any cost, right? So with that, I start with today's series or today's session of questions. So it says a child presented with jaundice, inability to drink milk. On examination, oil drop cataract is seen. What is the most likely diagnosis? Now tell me, what is the answer? So here, with this question, I would like to tell you one thing, that might be you do not know anything about the question. It might be at times you do not understand what is the question. So in such types, hi cardiologist, so in such questions, you have to pick up that one hint which tells you everything. So, okay, so there is this clinical scenario where they say there's jaundice, there's inability to drink milk, which let's supposedly say, I do not know what they are talking about. But if I know my ophthalm well, the classic thing here is oil drop cataract. So whenever there's a question, there's a case scenario. So in that case scenario, just do not panic if you do not understand, you don't come to a point. There will always be one or two hints which will take you to that direction. So here in this question, when we are talking about it, there is inability to drink milk. That means, what does that mean? Cardiologist Mukul Singh and Nirmala all say A. Absolutely. But I want you to learn more than just galactosemia. So that is my target. And my target is that my students should be able to answer without looking at the options. So now if I tell you this question, so the topic that we need to learn is galactosemia. The important thing to learn here is, what is the issue in galactosemia? So when we talk of galactosemia, the issue is that we are unable to convert from galactose to glucose, right? So the milk here is the important thing. So milk has, what does milk has? Milk has galactose. And in galactosemia, the problem is we are unable to convert it to glucose. And galactosemia is primarily because of deficiency of three important enzymes involved in galactose metabolism. And out of these three important enzymes, so let's learn. So when we talk of galactosemia, we need to know in galactosemia, so basically, since galactose is not being converted to glucose, galactose is being transferred into the tissues and converted to galactitol. So now what happens is there is deficiency of three enzymes. Most of the pediatric cataracts are autosomal dominant, except for galactosemia, which is an autosomal recessive inheritance. So most of the pediatric cataracts are bilateral and have an autosomal dominant inheritance, except for galactosemia, which is an autosomal recessive inheritance. Number two, we learned it has deficiency of three enzymes, out of which, what is the term? Classical galactosemia. Which enzyme is responsible for causing classical or classic galactosemia? Tell me, what is that enzyme? The answer is GPUT. So what is GPUT? Write down. It is galactose 1 phosphate uridyl transferase. Right? So that is one. So what is the classical appearance that you get in galactosemia? So the classical appearance that we get in galactosemia is this, in this image. What is shown in this image? Tell me. So what sign do you get to see in this image? So this is called as the, I'll take a darker color. This is called as the oil droplet cataract. So the classical explanation is oil droplet cataract. What are the other things that we get to see in galactosemia? There is brain involvement. There are cataracts. The classical is the oil droplet cataract. There is jaundice. There is enlarged liver, which is normally seen as the yellowish discoloration of the sclera. Then there will be kidney involvement. And in the classical history that you get is infant is unable to digest milk. Sugars build up and they result in a multi-organ damage. So this is galactosemia. Classical is oil droplet cataract. All developmental cataracts are autosomal dominant inheritance, except which is galactosemia, which is autosomal recessive. Classical galactosemia, GPUT deficiency. Classical cataract picture, oil droplet cataract. Which other conditions in ophthalmology do we need or do we learn about the term oil? So when we talk of other conditions where we tend to learn about oil, can you tell me? Anyone? Which other conditions do we learn about oil? Anyone who can just say, what is oil droplet reflex? What is oil droplet reflex? Also called as Charlie's sign. Where do you get to see it? Oil droplet reflex or Charlie's sign? Also, we have oil globule reflex or oil globule appearance. So now you have to tell me, where do we get to see this? So oil droplet reflex or Charlie's sign. Where do you see it? You see it in keratoconus. And oil globule oil appearance is, I'll draw the diagram. What is this condition? This is called as posterior lenticonus. Right? So now no confusions. Oil droplet reflex, Charlie's sign, keratoconus. Oil globule reflex, oil globule appearance, posterior keratoconus. Oil drop cataract, seen in cases of galactosemia. Is that point clear? So no more wrong answers when this part is concerned, right? So the answer here is, so what is the answer? The answer here is galactosemia. Can it be a nuclear cataract? No, it cannot be a nuclear cataract. Can it be a polar cataract? We have already learned where do you get anterior and posterior polar cataracts. So the answer here is classically inability to drink milk was one hint, and the other hint is oil droplet cataract. So now we moved on to the other topic, which says, so what you have, what did you learn from here? You have metabolic diseases. right? So all systemic diseases and their classical appearances. So the thing to learn from here is what you should know and what you should remember is systemic diseases and its classical appearances is what you need to learn. All right. So then we move on to this question: in which grade of hypertensive retinopathy? So all the vascular causes, all the vascular retinal lesions are very, very important. They include hypertensive, they include diabetic retinopathy, they include venous occlusions, and that includes arterial occlusions. So now we come down to this. It says in cases of hypertensive retinopathy, cotton wool spots are seen according to Keith Wagner classification. Which grading is this? Tell me, which grading is this? Anyone? So what is the full form of Keith Wagner classification? So the full form of Keith Wagner classification is, anybody? This is called as Keith Wagner Barker classification. So now tell me, what is the grading? So when we talk of grade 1, we talk of generalized arteriolar attenuation. Okay, so now what are we discussing? Keith Wagner Barker classification of hypertensive retinopathy. So that is a generalized arterial attenuation. When we talk of grade 2, it means arteriovenous nipping. So what I advise everyone around is, whenever we are discussing things like this, the gradings, the important classical names, you should always write it down on the rough paper that you have with you. Because otherwise, once this closes, tends to get out of your mind. Okay, so you should write it along with me. So there is arteriovenous nipping plus focal attenuation. Then we come to what is grade 3? By grade 3, please remember retinopathy. So when I say retinopathy, by that what do I mean? By retinopathy, we mean we cover cotton wool spots, we cover hemorrhages, and we also cover exudation. Easy? So that is grade 3. And when I talk of grade 4 is grade 3 plus papilledema. So the point to remember here is, let's discuss what are the important words to remember. Whenever the question talks about generalized arterial attenuation, we are talking of grading 1. When the term is focal attenuation, there is grading 2. But whenever retinopathy sets in, that means there is involvement of cotton wool spots, there is involvement of hemorrhages, or the question talks about exudation, we are talking about grade 3. And whenever the question talks about papilledema, we are talking about grade 4. So now tell me, what is the answer? So Keith Wagner Barker classification, what is the answer? The answer here is, we are talking about grade 3. Can you tell me what are the other classifications of hypertensive retinopathy? So the other classifications is, there's a Mitchell and Wong classification and there's a modified Shies classification. So the other classifications that we can talk of, now the question to discuss is hypertensive retinopathy. So let's see, what all should we know about hypertensive retinopathy? Hypertensive retinopathy, hypertensive ocular changes, classically. So the hypertensive retinopathy, when we say, that is when the hypertension is predominantly affecting the retina. We call it as hypertensive retinopathy. But once it affects the choroid, we call it as hypertensive choroidopathy. And when the optic nerve is involved, we call it as hypertensive neuropathy. So, which layers of the ocular tissue can be affected by hypertension? Is it retina? Is it choroid? Is it optic nerve? Or is it all of these? The answer is all of these. So, it can affect the optic nerve, it can affect choroid, it can affect the retina. And what is the predominant involvement in hypertension? What is the point of affection in hypertension? So what is affected? Hypertension basically affects the arterioles and capillaries. Okay, so now you need to know what are the signs. When we talk of these signs, as I told you, there will be a generalized attenuation, which is seen in grade 1. There will be focal attenuation and arteriovenous nipping. So AV changes, arteriovenous changes, is the hallmark of hypertensive retinopathy. Okay, so arteriovenous changes is actually the hallmark. So, what are the arteriovenous changes that we know of? They can be Salus sign. It is gun sign. And it is bonnet sign. Right? Also, I told you there will be changes of retinopathy. That means there will be presence of these cotton wool spots. So what is these? These are the cotton wool spots. Then what do you see in red? Here, these are the hemorrhages. And what do you see here in yellow? What are these? These are the exudates or hard lipids. Okay, so the lipid deposits. What are cotton wool spots? They are RNFL infarcts. So these are the changes of hypertensive retinopathy. So this you should remember, right? So what are the, as I told you, what are the other classifications? The other classifications that we deal, the other classifications that we have are, one we have learned is Keith, Wegener and Barker classification. Also, we have a modified Shies classification. And last but not the least is a Mitchell-Wong classification. Okay, so these are the important questions that need to be covered when we are talking about hypertension and eye. And effectively, the treatment is control of blood pressure. Control of blood pressure. So this you should know. All right. So you can have hypertensive retinopathy, hypertensive choroidopathy, or hypertensive neuropathy. Right? It affects the arterioles and the capillaries, and you should always remember what is the grading according to the Keith Wagner Barker classification, which is an important classification system, and what are the other classification methods that we have. All right. Okay. So the next important question is, what are the yoke muscles of levodepression? So now here I want to make it a point to be notified. This question, yoke muscles, has been from July 2023. But a similar question was in the same year in January 2023. Which of the following is the yoke muscle of right lateral rectus? So here the question is yoke muscle of right lateral rectus. Here the question is yoke muscle of levodepression. So this question was asked in January, and 6 months later it is asking the same question about yoke muscles. So this is exactly what I'm trying to tell you, that if you have covered that topic well, you know what you are dealing with. So whenever we talk of these important terms, the terminology of squint and group of muscles involved, muscles, their action is important. Okay, so now let's see what are we talking about. Good evening, Debraj. I think you've joined a little late. We have covered some questions, but never mind. You can, always go back and see from the beginning. And right now with us, you can just revise. So now, first you need to tell me, what do you mean by the term yoke muscles? What are yoke muscles? So there are two terms which I want you to clear first. One is yoke muscles, and what is the term synergist? Tell me, what is synergist and what is yoke muscle? Anybody who wants to attempt to this? See, whenever we talk of the term synergist, please remember, the way to remember is S for synergist and S for same eye. So the group of muscles which are involved in the movement, in a particular movement, in the same eye. So the pair of muscles involved in a particular movement in the same eye are called the synergists. But what are yoke muscles? The way to remember is contralateral synergist. Right? So here the pair of muscles, one in each eye, which are involved in the movement are yoke muscles. Is this point clear? Absolutely. So yoke is opposite. Yoke are contralateral synergist. S for synergist and S for the same means they are acting the group of muscles, the pair of muscles in the same eye. For example, if we take an example here, and the beautiful example here is when we talk of synergist. So, what is the group of muscles which are involved in elevation? So, for elevation, the muscles are, if we talk in the right eye, it is right superior rectus and right inferior oblique are responsible for elevation. So these are the synergist muscles, because here we are talking of the group pair of muscles in the same eye, Whereas when I talk of yoke muscles, that means if I have to look, there is for dextroversion. Here, this is my right eye. If I want to look here, my right lateral rectus would work here, which would abduct this eye, and my left medial rectus would work. Why? Because when I have to look towards the right side, my right eye needs to go out and my left eye needs to go nasally, needs to go medially. So what are the yoke muscles? It is right lateral rectus and left medial rectus. Is that point clear? Oh, thank you, Devraj. Thank you so much for that. But never mind, it's okay. I'm always available to discuss whatever queries you have on the Unacademy app. You can post your queries and I'll be so happy to answer them. Right? All right. So next we come down to this. So what we talking? So dextroversion. So now you get that. So these are the set of yoke muscles. Why yoke muscles are we calling them? Because here the group of muscles is one in the right eye and one in the left eye. Now, is that point clear to everyone? So what is synergist and what is yoke muscle? So now there should be no confusion. Now we come down to this question. What does this say? So what are the yoke muscles for levodepression? So the question they asked in January was a simpler one. So they asked what is the yoke muscle of right lateral rectus. So tell me which is the yoke muscle of right lateral rectus? It is, so whenever yoke word comes to you in the question, now here if it is right, it is common sense that you have to look for the word left in the answer. So that's an easier way to handle it. So whenever you have yoke and you have to look for the contralateral muscle. So yoke muscle of right eye needs to have left in its left. It has to be from the left eye. So the only option here which was from the left eye is left medial rectus. And this is exactly what we have discussed. This is exactly what we have discussed. So right lateral rectus, left medial rectus. But the yoke muscle question, when it came 6 months again, after 6 months when it came, it was to a little higher level. So this is what exactly I'm telling you. Do not think that the same question would be repeated, but you should know that topic well. And that is my aim, that if you listen to these lectures, you would not need to at least revise these topics. Multiple doing them through my lectures, through these notes would be enough. Okay, so now we come to what are we talking in levodepression. So the question here is talking of levodepression. Now the question it talked of levodepression. So what does the term levodepression means? Levodepression means depression towards left. Right? Depression towards left. So this movement, just see, this is my left side. So in looking down towards the left is levodepression. So when we talk of levodepression, what are the muscles involved? So when I talk of levodepression, please note from the left eye, what are the depressors? The left eye depressors are inferior rectus and superior oblique. And what are the right eye depressors? Again, inferior rectus and superior oblique. That's clear? So now the catch point is you have to see, when I talk of levodepression, one eye, there has to be a depressor which acts in abduction, which is for the left eye, and in the right eye, there's depression in adduction. So this is the movement. And once this is the movement, so for left eye, depression in abduction, which muscle is responsible out of these two for depression in abduction? Anyone? So the mnemonic to remember is, as I always say, rub. So rub is a Punjabi word for cord. By rub I mean recti. Recti act predominantly in abduction. So when I'm talking of left eye depression in abduction, what would work? Inferior recti would work. So left eye inferior rectus would work. And when I'm talking of right eye, I'm talking of depression in adduction. So recti would work in abduction. So what would work in adduction? Superior oblique. So right superior oblique would work. So what is the answer? It is left inferior rectus with right superior. Is it clear, everyone? Because this is very, very important. Very, very important. When I talk of muscles, you should know their primary, secondary, and tertiary action. Is this point clear, everyone? This should have no confusion. So now you know what is synergist, what are superior rectus, what are obliques, what are recti, where do they work, how do they work. Is that point clear? If yes, give me a thumbs up and I will move ahead. Okay, so again, so you saw there was a question in January, and again, the similar topic was repeated in July. So that is the reason we push so much into the previous year questions, because once they are repeated, there are direct gain of the marks. You gain on marks and you gain on time. All right. Thank you, Debraj. So now we come to a patient comes to us with visual blurring. So this question I'm talking of is from July 2023. Patient comes to us with visual blurring. On examination, diagnosis is made according to the image given here. So this is the image which is given. Now you have to tell me what is the visual blurring called in this condition. So when we see the image, what do we see? Let's see. When we see the image, we see that the disc margins are indistinct. Disc margins are blurred. Number two, you see there is an elevation. See the look at the loop of the blood vessel. So the disc margins are blurred. So what are the findings? The findings are disc margins are blurred. There is disc edema. And last but not the least, what are these? These are disc peripapillary hemorrhages. These are peripapillary hemorrhages. So when you look at this, so when you talk of visual blurring in such conditions, when you're talking of edematous disc, disc margins indistinct, hemorrhages around the disc, what are we talking of? Tell me, what is the diagnosis? The diagnosis is we're dealing with something related to papillitis. There is inflammation at the optic nerve head, right? And the answer here is anybody who wants to attempt, you say central retinal vein occlusion, Nirmala. Well, I would vary here. Let's see. Is it amaurosis fugax? What is amaurosis fugax? Tell me. Amaurosis fugax, when we talk, is actually a temporary obscuration of vision. And usually it is due to vascular disturbance. So amaurosis fugax. Basically, there is a temporary obscuration of vision. So is it like that? It happens when there is an involvement of the disc. So that is one. The other thing that we have is central retinal artery occlusion. Third is central retinal vein occlusion and hypertensive retinopathy. We just read about hypertensive retinopathy. I told you there's involvement of the nerve. There can be involvement of the nerve, but here no other finding in the fundus has been suggested which says hypertensive. If hypertensive retinopathy would have been the answer, the question would mention changes in the arteriovenous signs, or would have mentioned that the patient is a hypertensive, or would have the changes of a generalized arteriolar attenuation, but nothing is mentioned in the question. So this goes out. Then we are left with three options. Now let's see one by one. So now what do you see on your screen? Now when you see an image like this, what is this? We talked of option C as vein occlusions. So what are vein occlusions? So when a branch is obscured, when a branch vein is occluded, is blocked. Whenever we talk of veins, please understand the concept that veins are tributaries. So when we talk of veins are tributaries, they are carrying the blood from the retina into the disc via the vein. So this is the flow in veins. So I repeat, what is the flow in the veins? Like this. This is the flow in the veins, and like this is the flow in the artery. So if the vein is blocked here, that means something which is coming, which is pouring in, has been blocked. By that, it's a simple example of when we blow a balloon. The balloon stretches, 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 stretches. So there's a limit till what it can stretch. But if you keep blowing in more air beyond its capacity and it goes bump, so that is exactly what is happening with the veins. There is blood flow coming from here into the vein. These are the tributaries, but there is an occlusion here. So once you keep pouring, 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 it expands, 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 and it goes bump. So that is where you get the clots. That is where you get the hemorrhages. So whenever you have a picture where you have hemorrhages like these, so what do you have? When you have hemorrhages, when you have cotton wool spots, when you have arteriovenous changes, please remember the classical appearance of venous occlusion. So what are we talking? We are talking about venous occlusions. So now the thing is, how do you differentiate whether it is a branch retinal vein occlusion or it's a central retinal vein occlusion? It's very, very, very simple. When a quadrant is involved, when a quadrant is involved, as in this, then it is a branch retinal vein occlusion. But when you get the changes like this, which is present throughout the fundus, once these hemorrhages are present in all the quadrants, once there is involvement of all quadrants, when there is hemorrhages all over the fundus, is what you are dealing with is central retinal vein occlusion. And what do you call it? You call it as a splashed tomato appearance. By that I mean if I throw the tomato on the wall, it splashes. So there is, red pulp all around on the wall. So like that, when you get, it is called a central retinal vein occlusion, splashed tomato appearance, and when there are hemorrhages in all the quadrants. When there are hemorrhages in all the quadrants. So that is the picture. When you have blood, you have hemorrhages on the retina, you have cotton wool spots. These are the pictures of venous occlusion. So, but when we get a picture like this, so now please note that this question was asked in January 2023. And a similar question again asked in July 2023. So this is again, I told you, is a repetition. So what are you getting? You are getting the questions on vascular diseases. By that I mean hypertensive retinopathy, diabetic retinopathy, venous occlusions, and arterial occlusions are an important topic. Right? So now it says below image with the characteristic finding can be seen in. So again, it had the question was quite similar, but from a common topic. But it changed the way it was asked. So now if you have an appearance like this, what is the appearance? Tell me. What is the classical finding that is seen in this image? So what are you seeing? Let's talk about this first. So what all are we seeing? So what we see here is, you can see this white pale retina here, all whitish yellowish in color. So there is pale retina, and there's a beautiful red spot here in the center. So what is it called? Absolutely, Debraj. It is called as the cherry red spot. It is called as the cherry red spot. If it is not visible, I'll use the other color. It is called as The cherry red spot. And what other findings do you have? So you have this as an opaque retina, or what you call it as there is retinal edema. Right? So when we are talking of this, which condition are we talking of? Anybody who wants to attempt? What condition are we talking about? Is it central retinal artery occlusion? Is it central retinal vein occlusion? Is it cystoid macular edema? So another important thing to remember here is you should know the short forms also. So at times it might just give you options like this: central retinal artery occlusion, central retinal vein occlusion. What is CME? It is cystoid macular edema. Or none of the above. So tell me, what is the answer? Good, Devraj. The answer is central retinal artery occlusion. So now you saw so similar questions, so similar topics, and just 6 months apart. It is so much, gaining on marks. So this is CRO. So now you know what is CRO, and CRO is basically because of the embolus which is coming. Venous occlusion is because of the occlusion at the level of the arteriovenous cross section, and arterial occlusion is predominantly because of embolus. So from where does this embolus arise? Again, that's an important question. So when we talk of Hollenhorst plaques, they are the bright cholesterol emboli. They are the bright cholesterol emboli. Cholesterol emboli. From where do you get platelet fibrin emboli? Tell me. From where do you get the platelet fibrin emboli? So platelet fibrin emboli comes from arteriosclerosis. Okay. Now, where do you get to see the calcific emboli? Tell me. Where do you get to see the calcific emboli? So the calcific emboli come from diseased cardiac faults. From where does fat emboli come from? Fat long bone fractures. Okay. Septic emboli. So what is the source of septic emboli? The septic emboli comes from infective endocarditis. Yes, Renu, you're right. They come from fracture, but what you need to add on to your learning here is long bone fractures. Septic emboli come from infective endocarditis, and talc emboli comes from intravenous drug users. Okay, so now you know how does CRO looks like. You know how does CRVO looks like. So central retinal vein occlusion goes out, because here what you will get a cherry red spot. But there is no cherry red spot in the question. Then central retinal arterial occlusion. No, sorry. I have written it wrongly here. It is the central retinal artery occlusion where you get the cherry red spot. When you talk of vein, you have hemorrhages which can be splashed tomato appearance. So what is the answer here? The answer here is amaurosis fugax. The answer here is amaurosis fugax. So which is a temporary obscuration of vision, which is actually rightly said as the transient obscuration of vision. It is so called the transient obscuration of vision, and mostly because of vascular causes. So now you know this image, it should be in your mind when you have these hemorrhages. It can be a venous occlusion or it can be a central retinal vein occlusion. You have a cherry red spot, we talk of central retinal artery occlusion. And what is important here is, the important thing to remember here is the cause for the arterial occlusions is an embolus, and all you have to remember what is the source of the embolus. When we talk of a Hollenhorst plaque, it is a bright yellow color emboli which has a cholesterol. It is of cholesterol origin and comes from atherosclerosis. Platelet fibrin emboli comes, the sources arteriosclerosis. Calcific emboli, the sources diseased cardiac valves. Fat emboli, the sources long bone fractures. Septic emboli, the sources infective endocarditis, and talc emboli, the sources intravenous drug users. And I will draw 5 stars here. This is a very, very important question. And if you sit without remembering this, you should just get up and move out yourself. But you can't do that because now you know it, right? So this is something which is very, very important. All right. So the next question that we move on to is, a patient presents to you with light reflex absent. With light reflex absent and accommodation reflex present. Whenever you talk of neuro-ophthalmology, the first session that we did, I told you visual field defects is a must. Visual pathway, visual field defects, pupillary reactions. So the important topics when we are talking from neuro-ophthalmology, visual pathway, so all of you must, jot down all these important topics on a piece of paper every time we learn it. So just keep a common paper and keep writing there. And if you're unable to do that, don't worry. I will give you the complete list on 28th when we meet at 9 p.m. in that special class, okay? Anyways, visual pathway. Then is the visual field defects. And last but not the least, the pupillary reactions and its defects. This is very, very important. So when we come to this question, it says light reflex absent. So I write it down as light reflex absent, but accommodation reflex present. So can you name 2 conditions where there is light reflex which is absent and accommodation reflex is present? And what do we call it? All right. So I have one answer as Ergyle Robertson pupil, right? That is one thing that you have answered. But you have to tell me what is the other condition where you can have this. So Nirmala, I'm sorry I didn't get that. 17, 18, 19. What does that mean? So this is basically when we call it as light near dissociation. So here what we are dealing with. Now look here carefully. If you try to observe carefully, there is anisocoria. By anisocoria, we mean there is difference in the size of the pupil. So if you see this is smaller, this is larger, but we do not know which is the defective pupil. So when we show light here, ideally there should be a direct pupillary reflex which comes and this should constrict, but this is the larger pupil. This is the larger pupil and there is no reflex to light. Why am I saying there's no reflex to light? Because the pupil is dilated. It should have constricted on light reflex. Okay. Oh yes, you meant to name the occipital lobe areas. Absolutely, Brodmann area number 17, 18, 19. Absolutely. Okay, so what we're dealing here, coming back to the question, so that is one observation from image A. So what you just saw, when we show the light to the eye, there is no direct reflex which is present. There is no constriction of the pupil. But when we go to the image B, here you're showing a pencil which is a near target, which you are giving as a near target. So when you give the near target, what do you see? Now compare the pupil size of these two eyes. You compare the pupil size here. You see this and this. It goes even smaller. But if you see carefully, compare this eye and now. So the pupil has gone smaller. The pupil has gone smaller as compared to this image. I will do it further. If you zoom and see this, the pupil has gone smaller. So on the near target, the pupil has constricted, which did not constrict on light reflex. Okay, so that is the second observation that we have. The third observation is when you remove the near target and then again you ask the patient to fixate at distance. Now you see carefully, compare the pupil of two eyes. This has become larger as compared to the left side. So that means there is slow redilation. So there is slow redilation, right? So there is a slow redilation. So what are we dealing with? Again, we have a pupil, which is, so the important things to remember here is we are dealing with pupil which is larger in size. There is no reaction to light. It constricts on near, and there is slow redilation on seeing at distance, and that is called as, which pupil is it? This is called as the Ades tonic pupil. So why do we call it tonic? Because there is a tone which is present, resulting in the slow redilation. So there's a tone which is present, resulting in a slow redilation. Is that point clear? So when the question says the involved pupil is larger, there is no light reflex, there is near reflex present, and there is a slow redilation. So then we are talking of Ades tonic pupil. So that is the best way I can explain this. And where do you get to see this? Here there is issue, there is a lesion of the ciliary canal. So that is the Ades tonic pupil. So when we go back to the question here, so now let's see what are we dealing with. So it says light reflex absent, accommodation reflex present. I said light near dissociation. You told me one pupil, which is Argyll Robertson pupil, or Argyll Roberts ARP, and now tell me which is the other pupil that we just discussed, which gives you light near dissociation. Now tell me the two answers. You just write it down in the chat box. Now you all know what are the two conditions where you get to have a light near dissociation. Tell me. Good, Renu. So one is Ades tonic pupil, and which is the second? Which is the second? So write them together for you to remember. So two pupils which follow the light near dissociation is Aidstonic pupil and I'm still waiting. And good, Renu. It is a Guy Robertson pupil. So the answer here is, now you all know the answer is Guy Robertson pupil. Is it RAPD? What is the full form of RAPD? RAPD means relative afferent pupillary defect, or it is famously called as the Marcus gun pupil, right? So where do you get to see this? In the diseases of optic nerve, like optic neuritis. So afferent means something which is carrying towards the brain, that is the optic nerve. Then, so RAPD is not the option, Marcus gun is not the option. Wernicke's hemianopic pupil, classically seen in the lesions of optic tract. So Wernicke's hemianopic. So by hemianopic, I mean whenever there's a lesion of the optic tract, we did learn it gives you a contralateral homonymous hemianopia. And in that area of homonymous hemianopia, when you show the light, there is no reflex that you tend to see. So that is called as Wernicke's hemianopic pupil. Is that point clear? So can we move ahead now? So you know where do you get to see light near dissociation, you know what is RAPD, you know what is Marcus gun pupil, and you know what is Wernicke's hemianopic pupil. So these are the very important reactions, very important questions that you must know. Okay, so now we move on to the next question. So there was again this question on short-term corneal preservatives in July 2023, which is again a very important topic. I normally cover this in advanced ophthalmology, but see, you have it here. So let's quickly know what is eye banking and what is the preservatives that we use. So when we talk of the optimal time of retrieval of the tissue, that is around 6 hours. The optimal time. So there is a difference now. When I talk of optimal time, the answer is 6 hours. But we can take the tissue till 24 hours. You can take the tissue till 24 hours. But when I take off optimal time or the ideal time, it is 6 hours. What is the minimal acceptable cell count? That is around 2000 cells per millimeter square. And how do you preserve the tissue? That is very, very important. So what you have is, you have a short-term storage, you have intermediate storage, and you have long-term storage. So what is short-term storage? When we talk of the short-term storage, we have the moist chamber and the MK media. Okay. When we talk of the intermediate storage, we have U-Sol, we have Cornisol, we have Optisol GS, and we also have Life GE medium, right? And what are the long-term storage? In long-term storage, we have organ culture, we have glycerine preservation, and we have cryopreservation. Okay, so if you want to know the details about them, you can listen to the advanced ophthalmology lectures which are available on on Unacademy app, right? So these are the important storage media and with their time durations: short-term storage, intermediate storage, and long-term storage, right? So this you need to remember. This is again important. Eye banking, corneal tissues, diseases that are transmitted through donor cornea, what are the reactions of corneal transplantation, what are the signs of graft failure are all very important. What are the types of keratoplasty? Again, important. So anything which is related to keratoplasty and eye banking is important. Though it is advanced, but see, it has been asked. So keratoplasty and eye banking. Okay, all right. So now we move on to the other one, which says drug used for refraction in a child presenting with squint. Presenting with squint. So here they have just twisted the question a bit. Presenting with squint. Drug used for refraction in a child presenting with squint. It is the same question had they been asked drug used for refraction in a child for the first time. If you have a baseline first time refraction in a child, which drug do you use? You say the answer is C. I would rather say this. You should know it is the strongest cycloplegic. That is the way I remember it as. Okay? So what do you say? The drug which is used for refraction in a child when you're doing it for the first time, or the drug which is used in when the patient has squint is the one which is the strongest cycloplegic. And what is the answer? The answer is this, everyone should know, is atropine. Let's quickly revise what are the drugs which are used in refraction. So first thing, you should know their names. Second thing, you should know when do we use them. And third, you should know what is the maximum duration. Most of the questions is from these three topics. So what are the drugs that we can use for refraction? Or what is the other use of these drugs? That is mydriatics and cycloplegics for fundus evaluation, for cataract surgeries, for retinal surgeries. When you need to dilate the patient to have the maximal visualization, right? So let's see. So you can use these mydriatics and cycloplegics. The use is in refraction. So where do you use these drugs? Let's see. The use of these drugs is refraction for fundus evaluation and in surgeries. But the important thing to remember here is when you're just talking about fundus evaluation, you can use a drug which is a mydriatic but not cycloplegic. So what is the difference? Mydriatic is the one which dilates the pupil. Cycloplegic is the one which paralyzes accommodation. So there is the difference between the two. It might be a mydriatic, but not necessarily a cycloplegic. It will not paralyze accommodation. But all cycloplegics are mydriatics. All cycloplegics are mydriatics. That means they dilate the pupil also. Is that point clear? Child needs strong mydriatic? No, Renu. Child needs strong cycloplegic. So you get the difference? Mydriatic will just dilate the fundus, but you need a cycloplegic that will paralyze, that will relax the accommodation. So do you get the difference? So child needs a strong cycloplegic because the accommodation is very strong in children. So is that point clear to you, Renu? So that is a difference, okay? Okay, so let's see. So the drugs that are used now, let's see one by one. The drugs which are used for refraction are atropine, homatropine, cyclopentolate, tropicamide, and phenylephrine. So tropicamide can be used alone or in combination with phenylephrine. So there's a difference, okay? So let's see. When we talk of atropine, the important things to remember here is when we talk of atropine, this has to be used in children who are presenting for first time refraction, who are presenting with squint, right? So this is to be used in children less than 8 years of age and to be used in children who are presenting with squint, who are presenting with squint or for the first refraction. So in children less than 8 years of age. And the effect here lasts for 10 to 20 days. On an average, this is 14 days. Is that all right? Do you get that? So this is atropine. The other that we have is from atropine, a derivative homatropine. So what is that? That is normally used for children between 5 to 8 years. Between 5 to 8 years or a follow-up refraction, you can use homatropine. Homatropine, the duration lasts for 2 to 3 days. So it is the shorter acting form of atropine. So atropine effect lasts for up to 2 weeks, up to 10 days, up to 14 days. But homatropine effects last only till 2 to 3 days, right? And the peak effect comes in 60 to 90 minutes. So this is homatropine. The third important cycloplegic is cyclopentolate. So when we talk of cyclopentolate, it is used in children who are more than 8 years. So 8 to 20 years, you can use cyclopentolate or you can also use tropicamide. So when we talk of cyclopentolate, the maximum effect comes in around 1.5 hours, and it is again short acting. The effect goes in less than 1 day. So it is shorter acting. That is cyclopentolate. When we talk of tropicamide and tropicamide plus phenylephrine, so this is used as a mydriatic. It is a poor cycloplegic. But the drug which is only mydriatic, is phenylephrine. This is only mydriatic. There is no cycloplegia. So the drug with no cycloplegic effect, phenylephrine. The drug with the poor cycloplegic effect, tropicamide. The drug with the strongest cycloplegic effect, atropine. Do you get the difference between the three now? Tropicamide is very short acting. The effect goes in 4 to 6 hours. Do you get that difference now? So the drug which is only mydriatic, phenylephrine. The drug which is poor cycloplegic, tropicamide. The drug which is the strongest cycloplegic, atropine. Is that point clear? Give me a thumbs up and then I'll go further. Is that okay? Longest acting, atropine. Shortest acting, tropicamide. Used in children with squint, atropine. Used up for follow-up evaluation refraction in children, which is homatropine. Or you can also use cyclopentolate. Used most commonly in adults is tropicamide, with or without phenylephrine. Okay, so this is the difference. So which is, or now you have to tell me, if you are a retina person and you have to evaluate the fundus, so which out of the following can be used? Do you need just a cycloplegic or just a mydriatric or a combination? So this is a very, very important concept. So when you have to do the fundus evaluation, just the mydriatric would also work. Right? Is that point clear? That is good. Okay. So now we move on to the next one. Identify this image. What is this called? What is this called? I just need two fancy names for this image. What do we call it? And the one that it recognizes is my favorite animal, raccoon sign. One, and also called as, you are right. We call it as raccoon sign, or also called as, it's my favorite animal, that is a panda. So these is also called as panda eyes. And which condition do you get to see these? Which condition do you get to see these raccoon eyes or panda eyes? You get to see them in the fracture of base of skull. So what are these? These is a bilateral ecchymosis. Okay, raccoon sign, panda eyes, seen in the base of skull fracture, and is bilateral ecchymosis. Ecchymosis means there's a hemorrhage which is present around the eyes. Okay, so now we have another question which says a known case of HIV with reduced CD4 count. So let's mark what are the hints in the question. I always say whenever you attempt the question, please do not go through. I will read the question once and then again I will start marking. No, when you are sitting in the exam, you're fighting against time. You are competing with other people. You are fighting against time. You have to finish all the questions. It has to be attempted. So right there and then, when you are reading the question, please mark the important points. So that means a known case of HIV with reduced CD4 count, and make this a habit whenever you are attempting these questions. Okay, a known case of HIV with reduced CD4 count presents to an ophthalmologist with the below given fundus finding. What is the drug of choice? So here I would want you to see the images only. So these were the images which were given, image A and image B. Okay, so you have to tell me what is the drug of choice. So here it is asking drug of choice. So all you have to highlight, that important tip is whenever you see a question, read it, highlight the important points, and always, always when you read the word except, write it separately on the question itself, because while thinking about the answer we tend to forget if it was written except. That's the most common mistake that we all of us do. Okay, so now we come to what are we dealing with. The hint says HIV reduced CD4 count. You don't even need to look at the images. You know what you are dealing with when you have come to an ophthalmologist in a patient of HIV with reduced CD4 count. Tell me, what are we dealing with? Tell me the name of the disease. What are we dealing with? Heart? See, it is just not talking of HIV. It is talking of HIV with reduced CD4. And these images. What is the most frequent opportunistic infection in AIDS? That is my point. Most frequent opportunistic infections in AIDS when the CD4 cell count goes below 50 cells per millimeter square. Now tell me, what is the answer? Absolutely, Harish. Very good. The answer is, it is CMV retinitis. The answer is CMV retinitis. What is this that you're dealing with? This is called as the pizza pie appearance, or it is called as sauce and cheese appearance. By that I mean it looks like the base of the pizza as I have shown here. So this is the retina which exactly looks like pizza. So it is called as the pizza pie appearance, sauce and cheese appearance, or what is also called as the frosted branchitis. So where do we get it? We get it in CMV retinitis. So it is seen in immunocompromised patients when the CD4 count goes less than 50 cells per millimeter square. And it is the most common ophthalmic manifestation of a congenital CMV infection. So now coming back to the question, what is the drug of choice of CMV retinitis? Pizza pie appearance, or what you call as that sauce and cheese appearance, that is CMV retinitis. What is the drug of choice of CMV retinitis? Tell me, what is the drug of choice of CMV retinitis? Drug of choice of CMV retinitis is, the answer is ganciclovir. So now you know why the answer is not D, because it is just not talking of HIV. It has HIV with a reduced CD4 count, and most common opportunistic infections in patients with reduced CD4 count is CMV retinitis, CMV, and presenting as CMV retinitis. So now this is the art of solving the questions, right? So now we come to the next one. It says male with a history of liver disease. So now we're done with July 2023 questions. Now on, we start with some we did cover in the previous one, which were the overlapping. Now we start with January 2023 session. So it says male with a history of liver disease developed a cataract as shown in the image. Which substance is deposited in the cornea? Which substance is deposited in the cornea? So a similar question was asked in July 2023. Remember the first session, we did learn fracture ring is the deposition of, and just 6 months before it was asking which substance is deposited in the cornea. Again, we come down to systemic diseases and eye. It is again and again questioning about the ocular involvement in systemic diseases. So now you have to tell me which disease are we dealing with when the question is talking about liver disease, cataract, and some random finding here in the question. So let's see. We see two images. This is image A and this is image B. Tell me, what are you seeing in image A? Look carefully. What are you seeing? What are you seeing in image A? So if you see carefully, look at this spot. What do you see? You see a golden brown deposition. What is it called? A golden brown deposition in the peripheral part of the cornea. And what do you call it? What do you call it? Tell me. This is at the level of Descemet's membrane. What do you call it? We did discuss in the session one also. Similarly, you have this is the presentation at the level of cornea. But in the lens, it has cataract like this, where there is brownish discoloration in the center with centrifugal extensions. So now you have to tell me what is image A and what is image B. So image A is basically the KF ring. The image A is KF ring. What is KF ring? We just learnt in session 1 also. It is called as the Kaiser flesure ring, which is the golden brown deposition at the level of Descemet's membrane of what? Of which substance? Of which substance it is? And similarly, what you see in image B is there is brownish deposition in the center of the lens and centrifugal extensions, and this is called as sunflower cataract. So what are we dealing with? When I'm talking of a sunflower cataract, when I'm talking of the KF ring, what are we dealing with? We are dealing with Wilson's disease, also called as hepatolenticular degeneration, also called as hepatolenticular degeneration. And hepatolenticular degeneration, Wilson's disease, is a defective metabolism of copper. There is a defect in copper metabolism. Defect in copper metabolism. So that is Wilson's disease. So where do you get KF ring and sunflower cataract? You get them in Wilson's disease. You get them in hepatolenticular degeneration, which is, what is that? They are the defective copper metabolism. They are defect in the copper metabolism. So what is deposited here? Copper is deposited here. A similar question was asked, as I told you, in July 2023, which talked of Fletcher ring. So what is Fletcher ring? That is the deposition of Fletcher ring is seen in which condition? Fletcher ring is seen in keratoconus. This is seen in keratoconus. So what is Fletcher ring? But Fletcher ring is the deposition of iron. This is the deposition of iron at the base of the cone at the level of basal epithelium. All right. So this is very, very important. Right. So I think I'll take a break here. We'll call it a day now. Enough we've learned, enough said and talked about. So before I close, I would want you again to remember, to remind as a reminder that we meet on 28th August, 9 p.m. on Unacademy app. This is a free session. This is a free 1 hour session, which is going to be a high yielding session, because over and over again I have got this so many times, the request to cover lasers and retained intraocular fluid bodies, which would cover siderosis bulbi and chalcosis. So just note it down on your to-do list. We meet on 28th, 9 p.m. free session, 1 hour session, 9 o'clock. Right? So till then, I would always say, sleep well, but keep working hard. So to work hard, you need to have a lot of energy, and that comes from good rest. So nothing can, all those pills, all those multivitamins, nothing actually can replace a good sleep. So good 8 hours sleep when you want a lot of mental activity is what is required. Again and again, I just say there are two mantras to crack any exam. Number one, you should always be fresh when you are studying. You should always be interested, right? So that is one. And number two is revisions, reinforcements. You read a book and you close it, you will remember it for like 2 to 3 days, maybe a week, or maybe a 10 days duration. But after that, it's not only you, even me. If even I don't revise, I will forget it. So, with that tip, with that take, I'll call it off. I'll sign off and see you on 28th again on Unacademy app for the free 1 hour learning session. Right? So, till then, take care. Have a good sleep. Thank you all. It was lovely interacting. Take care. Good night.